your back, journey to 600. Today we're talking about special tests of the shoulder. So we'll go through by diagnosis, so special tests for impingement, rotator cuff, AC joint, labrum, biceps tendon, instability, and thoracic outlet. So starting off, impingement. Hawkins-Kennedy, near, and painful arc. So Hawkins-Kennedy and near are very similar because they both are passive tests and they both have that internal rotation component. And that internal rotation is to close down that subacromial space to reproduce those impingement symptoms. So Hawkins-Kennedy, you flex the elbow and shoulder to 90 degrees and partly in the scaption plane, and then forcibly internally rotate the shoulder. And then for near, you will internally rotate the shoulder first and stabilize the scapula and passively elevate the arm in the scapular plane, and then overpressure is applied at end range. The positive findings for both of these tests are reproduction of pain in the biceps region, lateral arm, or subacromial area, or limited range of motion when you compare bilaterally. Painful arc is a little different because you do this actively. So the patient is asked to actively abduct their arm, and for impingement, you're going to look at pain towards the end range around 160 to 180 degrees. Next, we're going to talk about rotator cuff, and we're going to break it down by muscles. So rotator cuff supraspinatus, that initiates shoulder abduction. So the two tests for supraspinatus that we're going to talk about today is the drop arm test and empty can. Drop arm, you're going to start by passively raising the arm to 90 degrees of abduction and ask the patient to hold that position. If they're able to hold the position, so they have the strength to hold the position, you're going to release the arm and ask the patient to lower the arm. A positive finding would be that they're unable to lower the arm, so they don't have any control, the arm just drops, or they have severe pain during lowering. The empty can test is kind of like an MMT, so you're going to put them in a position and then you will add resistance. So the position is the shoulder is placed at 90 degrees of elevation in the scapular plane. Elbows should be fully extended and the shoulder in full internal rotation, so a thumbs down position, and then resistance is provided at the distal arm in an inferior direction. So a positive finding there would be dropping of the arm, weakness, or pain. Next muscle group is the infraspinatus and teres minor. So these are external rotators. So both of these are going to have some kind of external rotation component. The ER lag sign is going to be similar to the drop arm because you are going to put them in a position and ask them to hold it. This one you will not get them to move it. You will just ask them to hold the position. So you'll place the elbow 90 degrees of flexion and the shoulder in 15 to 20 degrees of scaption and passively externally rotate the shoulder to near end range like the picture and ask the patient to maintain this position. You are looking for the lag, so basically if they can't hold this position, if they have a 10 degree of lag, then that can indicate the infraspinatus, and if they have a 40 degree lag, that can indicate the teres minor. Next, the hornblower sign. You're going to elevate the patient's arm to 90 degrees in the scapular plane and flex the elbow to 90. So kind of overhead in external rotation. Patient is instructed to externally rotate the arm against manual resistance. So again, this is similar to the empty can because it's kind of like an MMT. You're going to put them in position and then add resistance. Positive finding for hornblowers is unable to externally rotate due to pain or weakness. Next muscle of the rotator cuff we're going to talk about is the subscapularis. So the subscapularis is an internal rotator, and the two tests for that are lift off and belly press. Lift off, you're going to get the patient to put the back of their hand on their back, and the patient is instructed to lift the hand away from the back. So basically they're going to try to actively internally rotate from that position. If the patient is able to lift the hand away from the back, resistance can be applied by pushing the hand towards the back. A positive finding for the lift off sign is unable to lift off or hold the position against resistance. The belly press is going to be starting from the front of the body Then you will ask the patient to place a hand on their stomach with the elbow flexed to 90 degrees. The patient is instructed to internally rotate the shoulder, causing the palm of the hand to press into the stomach. Positive findings for this test: if the elbow drops behind the body into extension, reproduction of pain with activation, or you also need to watch for wrist flexion compensation over shoulder internal rotation. So rotator cuff pathology in general, grouping it all together. So typically rotator cuff pathology happens in acute situations with overhead throwing, fall on an outstretched arm or hand, lifting heavy objects, and it can be associated with other injuries related to dislocation of labral tears. So typically that referred pain is along the lateral deltoid and arm, has a localized tender to palpate on the greater or lesser tubercle and bicipital groove, kind of depending on which muscle is torn. They will have increased symptoms with overhead activities, lifting objects, and reaching hand behind their back. And any of these 6 tests we just talked about will indicate that rotator cuff pathology and specifically which muscle, depending on the positive finding from the special test. Next, we're going to talk about AC. Horizontal adduction test is self-explanatory. You're going to passively move them into horizontal adduction and apply overpressure at end range. And essentially, the positive test is just pain over the AC joint. The AC shear, you're going to cup your hands over the deltoid muscle with one hand on the clavicle and one hand on the spine of the scap, and you're going to squeeze the heels of your hands together. So you're going to shear that AC joint, and a positive finding would be pain reproduced at the bicipital groove. Again, painful arc, so we saw that with impingement. So again, at that top of the arc would be painful. 160 to 180 would also indicate AC, so you would cluster either AC test or impingement test to decide what pathology you have there. Next is labrum. Active compression test, also known as the O'Brien test, biceps load, and crank. Typically a labral tear, it can be caused due to a fall on an outstretched hand or repetitive overhead activities. This sounds familiar to the rotator cuff, so these can happen simultaneously or it can happen alone. There's different types of labral tear. So type 1 is through a degenerative process common in ages 40 and older, marked by fraying of the superior labrum. But type 2 is one that you're going to see most commonly with those overhead athletes. So it's when you have fraying of the superior labrum with a detached biceps. It typically occurs with those overhead athletes when they're in the maximal cocking phase of the throwing motion. That's what causes this type 2 labral tear. But they'll present with deep aching in the shoulder with diffuse upper trap pain. They might have reports of clicking, catching, popping with shoulder movements. Of course, pain with reaching overhead and behind their back and lifting objects. And then they might have a positive of one of these tests. So the active compression or O'Brien test, it's a 2-part test. So you will first have the patient's arm flexed to 90 degrees with elbow fully extended and arm is horizontally adducted, so across the body 10 to 15 degrees and internally rotated. So thumb down first. You're going to apply downward force just proximal to the wrist, and the patient is asked to report any symptoms. Then the test is repeated in the same position, but the shoulder will now be an external rotation with the thumbs up, and the symptoms are reported. So a positive finding would be pain or click deep in the shoulder in the first position that is lessened or relieved in the second position. Painful in both is not a positive test, so make sure you're asking for symptoms after both parts of that test. Biceps load, this one is really big to do for those baseball throw or any kind of overhead activity with throwing because of the position you're putting them in. So you'll have the shoulder abducted to 120 degrees and maximally externally rotated with the elbow flexed to 90. So really at that max cocking phase of throwing, forearm is placed in a supinated position, thumb down towards the floor, and patient is instructed to flex the elbow against resistance applied at the wrist. Positive finding for the biceps load would be superior shoulder and deep pain in the shoulder with contraction. Crank test performed in supine, you're going to abduct the arm to 160 degrees in the scapular plane. Then you're going to apply an axial load, so right straight down the humerus. And while you apply that axial load, you're going to internally and externally rotate the shoulder. A positive finding would be pain during rotation of the shoulder, and this can be present with or without a click. Next is the biceps tendon. So biceps tendon and labral tear kind of go together as well. But a biceps tendon pathology, it could just be tendonitis or tendinosis, but it does typically occur due to overuse or trauma, such as falling on an outstretched hand, catching heavy falling object. But they will present with pain along the anterior shoulder or bicipital groove with possible referral to the elbow. They will be tender palpated along that proximal biceps tendon. You might note some weakness, fatigue, pain noted with an MMT. And if they do have a tear, they might report a pop with a pop-eye deformity, so that means the biceps has rolled up. The test that you'll perform if you think that it's biceps will be speed or Jurgensen's. So speed, the shoulder is flexed and the elbow extended with forearm supinated. Manual resistance is applied to active shoulder flexion. A positive finding for the speeds test will be pain reproduced at the bicipital groove or deep in the shoulder. So this can be for biceps or labrum, kind of depending on where that pain is felt, in the bicipital groove or deep in the shoulder. Jurgensen's, so the patient's elbow will be flexed to 90 and stabilized against the trunk and forearm. Begins in a pronated position, so starting with their palm down, and you will be palpating over the bicipital groove. The patient is asked to supinate the forearm against manual resistance. So you have one hand at the top of the bicipital groove, you have one hand on the forearm providing manual resistance against their supination. A positive finding would be pain or tenderness at the biceps tendon, and you might feel the tendon pop out of the groove with palpation over the biceps tendon. So this is truly assessing the transverse humeral ligament integrity and how it's able to hold the biceps tendon in the bicipital groove. We are almost to the end. There's a lot of special tests for the shoulder, and honestly, we haven't even covered all of them. Just some of the ones that might be on the test. Shoulder instability. So we're going to talk about the apprehension test and the sulcus sign. So apprehension can be performed two ways to bias either the anterior capsule or the posterior capsule. You're going to do it in supine, kind of with the trunk supported. But for anterior, it's going to be the picture on the left. You're going to abduct the arm to 90 degrees, and then you're going to externally rotate the shoulder slowly. Why do you externally rotate? So the shoulder arthrokinematics, when you externally rotate the shoulder, that's going to cause the humerus to roll posterior and slide anterior. So you're putting them at the limit of the anterior capsule. If they have instability, you might see that the patient looks or feels apprehensive or alarmed or resists further motion. So that's the positive finding for apprehension. If you're trying to assess the posterior side, you're going to elevate the arm to 90 degrees in front of the body and then apply a posterior force on the elbow while internally rotating the arm. So again, when you internally rotate the arm, that's going to do the opposite. So it's going to roll anterior, slide posterior, but then you're also applying that posterior force to stress that posterior capsule. You're looking for the same thing if the patient looks or feels apprehensive or alarmed or resists further motion. So the sulcus sign is assessing the inferior capsule or multidirectional. So you're going to position the patient's arm in about 20 degrees of abduction and neutral rotation. Grasp the patient's forearm just below the elbow and apply a longitudinal traction force. So really pulling straight down. And you're going to see how much depression there is right under the acromion and the humeral head, or in that space. And you're going to compare to the contralateral shoulder to decide if there is a difference or instability in the shoulder. Lastly, thoracic outlet syndrome. So there's a lot of tests for thoracic outlet syndrome, and this is due to compression of a neural or vascular structures in the thoracic outlet region of the shoulder girdle. It's often due to bony or soft tissue anomalies, muscle spasm, or postural abnormalities. It's characterized by numbness and paresia of the arm and hand, clumsiness with the use of hand, or arm numbness and heaviness feeling. Symptoms increase with overhead activities, prolonged use of the arm, carrying heavy bags, maybe sleeping with their arm overhead. They might have some posture impairments like forward head, depressed shoulders, elevated first rib, and might also have overdevelopment of the neck, trapezius, and pec muscles. And they have weakness or decreased sensation in the C8 to T1 or C5 through C7 distributions, kind of depending on which nerve is compressed in their thoracic outlet region. The test to confirm thoracic outlet syndrome, Adson maneuver. So the arm is placed at 15 degrees of abduction and slight extension, and the patient is asked to rotate head towards the test side and tilt head back. Patient is then asked to inhale deeply and hold their breath. So you will palpate the radial pulse with Adson maneuver, and a positive finding will be absent or diminished pulse or reproduction of their paresthesia. Next, the Allen test. So again, you will monitor the radial pulse, but this time the patient abducts arm to 90 degrees and externally rotates his shoulder with elbows flexed to 90, and the patient's going to rotate their head away from the test shoulder. So a little different. Head is going to be rotated away, and their arm is now overhead versus down by their side. Same positive finding, absent or diminished pulse when the head is rotated away from the test shoulder. Next, the Roos test. So this one you can test bilaterally, and there's no radial pulse check. So you're just going to ask the patient to abduct their arms to 90 degrees and externally rotate their shoulders with elbows flexed to 90. Patient is asked to open and close the hands for 3 minutes. A positive finding would be ischemic pain, heaviness or profound weakness of arm, or paresthesia of the hand. So it's kind of like the Allen test where you have that arm overhead, but this one you do not have any rotation of the head or monitoring the radial pulse, and you're just going to get them to open their hands and close their hands for 3 minutes. Lastly is the hyperabduction test, or the Wright test. Place the patient's arm overhead in the frontal plane while monitoring the patient's radial pulse. A positive finding will be absent or diminished pulse. So 3 of these 4 tests will be monitoring the radial pulse. The Roos test, you do not monitor the radial pulse. So that's a good thing to know if a question is asking about thoracic outlet syndrome where you're monitoring the radial pulse. Roos test is not the answer, but you could have Adson, Allen, or hyperabduction as the correct answer. Okay, finally down to the practice questions. So which of the following special tests is being pictured to the right? A, Speed's test. B, Adson maneuver. C, O'Brien's test. D, Hawkins-Kennedy test. I'll give you a moment to answer. If you're not ready to review, please pause. This is not a case. It's not telling you any kind of pathology. It's just giving you a picture and figuring out what test it is. So with the new boards, there's going to be some more video questions, some more picture questions, and scenario-based questions. So it's really hard to guess unless you know one of the other tests. Like if I know what Speed's test is and you're like, oh, it's not that. But here are some pictures of all those tests so you can visualize it as we talk about it. So D is the right answer, Hawkins-Kennedy test. But the Speed's test is with shoulder flexion and elbow extension and forearm supination. That is for the bicep or labrum. Adson maneuver we just talked about. It is performed with shoulder extension and an external rotation with elbow extension, and that is for thoracic outlet syndrome. O'Brien's test, also called the active compression test. The shoulder is flexed, internally rotated, and horizontally adducted, and that is for labrum. This question is pretty straightforward, but you really have to know those special test pictures and what they look like. So D, Hawkins kidney test, is pictured here, and it is for shoulder impingement. Next question, a 35-year-old construction worker complains of difficulty working due to increased numbness, weakness, and pain in his right arm and hand. The numbness and weakness worsen when he lifts his arm over his head to perform tasks such as hammering. Which of the following special tests is most indicated? A, AC shear test, B, painful arc, C, ruse test, D, near test. I'll give you a moment to answer. Please pause if you're not ready to review. So this case is very clearly saying nerve issue related to thoracic outlet syndrome, and what screams that is the numbness, weakness, pain in the arm and the hand. So we need to determine which of these tests for thoracic outlet. The AC shear test, it's kind of in the name, so the AC shear test is for the AC joint. B, painful arc is for impingement or AC. D, the near test is for impingement. So C, the ruse test is the best answer. Ruse is for thoracic outlet syndrome, as well as Adson maneuver, Allen test, and hyperabduction test. So this has a lot of pathology related to it, and it doesn't tell you the pathology, but we did talk about special tests, so you should know just by reading the special test what pathology, and then relating what pathology is for this case. But we will do another video on pathology specifically at a later time. Last practice question. A 72-year-old tripped and fell on an outstretched arm. She complains of shoulder pain. Radiographs are negative for fracture and dislocation. Upon evaluation, you note a positive finding with the empty can test. Which is the most likely diagnosis? A, Teres minor tear. B, Subscapularis tear. C, Infraspinatus tear. D, Supraspinatus tear. I'll give you a moment to answer. Please pause if you're not ready to review. Fell on an outstretched arm. Could be a lot of things. So they're complaining of shoulder pain, not fracture dislocation. Upon evaluation, you note a positive finding for the empty can test. So empty can test, what does that look at? So empty can test is for rotator cuff, and it's for a specific muscle of the rotator cuff. So all these answers have rotator cuff muscles, but I know that the Infraspinatus and Teres minor are both external rotators, so it's likely not that answer because it's a little bit harder to distinguish those tests, or it's harder to distinguish those muscles since they both externally rotate. So Subscapularis is an internal rotator, and its tests are the belly press and the lift-off sign. Supraspinatus tear is indicated with empty can and drop arm. So D is the best answer, supraspinatus tear. Empty can and drop arm are supraspinatus tests. The ER lag sign and horn blowers are for the external rotators, and lift-off sign and belly press are for the internal rotators, which is the subscapularis. So D, supraspinatus tear. Again, this question has a lot of diagnosis type stuff, but it does tell you that there's an empty can test. With us talking about the special test today, you should be able to indicate that this was a supraspinatus tear just knowing from the empty can test. Thank you so much for watching. Don't forget to like this video, subscribe to our channel, and turn on notifications. See you next time on your journey to 600.